is a pleasure to welcome you all to a conversation about persistent Obamacare enrollment fraud. My name is Matt Robinson, and I am Executive Vice President of Paragon. We've all seen and heard stories about fraud in U.S. healthcare. Each week, there are new headlines. This year marks the third year in a row that Paragon has closely studied fraud and improper enrollment in Obamacare, specifically the Affordable Care Act exchanges. Our team wanted to do something special for this year's report, so we invited Alicia Finley to serve as our host and moderator. Alicia is an editorial board member at the Wall Street Journal and the paper's life science columnist. She has taken a leading role in covering healthcare and fraud issues across the nation, so we are thrilled to have her with us today. Alicia will serve as host, asking questions of Brian Blaze, president of Paragon, and El Minaric, one of his co-authors, exploring Paragon's recent research paper, The Persistent Obamacare Enrollment Fraud. They will discuss the simple but incisive methodology of the paper, as well as the implications of our findings and where the national debate will go next. Finally, we will open the floor to audience questions. You can submit questions at any time using the chat function on the bottom bar of your Zoom page. With that, I'm delighted to hand the program over to Alicia Finley. Alicia, the floor is yours.
Well, thanks. So Paragon was the first to shine a light on the magnitude of fraud and improper enrollment on the Obamacare exchanges and how the enhanced pandemic subsidies that were first enacted in 2021 turbocharged those incentives for brokers and enrollees to misstate incomes. Their work prompted Republicans in last year's tax bill and the Centers for Medicare and Medicaid Services to enact numerous reforms aimed at tightening verification checks and reducing the incentive for fraud. Yet Paragon's new paper suggests that even after the expiration of the sweetened pandemic subsidies and some of these moves to eliminate fraud still remains pervasive, with an estimated 6.2 million improper enrollments, which constitutes about a quarter of the Obamacare exchange enrollments. So here to discuss these findings and its implications are Brian and Elle. And so I just want to start off by asking you two how the process for enrolling in the exchanges, how all that works.
Hey, Alicia, thank you for moderating this discussion. Really appreciate your time and attention to this issue. Enrollment is complicated. There is an open enrollment season that is in the fall every year. During that process, the key is that people estimate their income for the next year. Now, why do they estimate their income? They estimate their income because Obamacare made health insurance much more expensive for people to purchase in the individual market. In order for people to afford that coverage, it included subsidies that go to health insurance companies that offset a portion of the premium. The subsidies are largely a function of people's income. Now, people don't know their income for the next year. So they, on their application, estimate their income. They then qualify for an advanced subsidy based on that estimated income. So every month that they're enrolled, the Treasury Department sends that subsidy amount to the insurance company. Now, many enrollees, and this is something that we're going to get to, didn't have any premium obligation. So they would have no actual premium that they would have to pay. But for other enrollees that did have a premium payment, they would then make the premium payment to the insurance company for that year. At the end of the year, so think about this in terms of 2026. When I file my 2026 income tax return, that's in the spring of 2027, I reconcile my advance subsidy, which was based on estimated income, with the actual subsidy that I was that I was legally entitled to. And there's a reconciliation process. There's been significant problems with how that reconciliation process has worked. But that's how enrollment works. Now, a lot of people that are enrolled in the program, they just get automatically re-enrolled in their plan. They don't have to take any actions. They just transfer from one year to the next and remain covered in their plan. And there's been some problems with automatic re-enrollment as well.
Okay. Now, in your study, as you mentioned, you estimate there are about 6.2 million improper enrollments this year, and that's actually a conservative estimate, I think you'd say. How did you define improper enrollment, and how did you come to that estimate?
Yeah, so an improper enrollee is somebody enrolled in the lowest income category. So that lowest income category is between 1 and 1.5 times the federal poverty line. And people in that income category qualify for the largest subsidy. So what we did was compare two sets of numbers by state. The first is the number of enrollees um, that claim income between 100 and 150 of the federal poverty line. The second set of numbers is what the Census Bureau says are people that are eligible um, in the state that have that income. So we exclude children because all children with that income are eligible for either Medicaid or the Children's Health Insurance Program. We exclude seniors because they're eligible for Medicare and not for subsidized exchanges. And then we exclude people that claim that they have Medicaid or Medicare. So that leaves the potentially eligible individuals. And improper enrollment is the difference between those two sets of numbers. And you can see on your screen, in 2024, we estimated 5.1 million improper enrollees. Improper enrollment reached its peak in 2025, which is the last year that the COVID enhanced subsidies were in place. It was about 6.5 million enrollees. And this year, it is still very high. It's still more than a quarter of enrollees at 6.2 million individuals. And you mentioned our estimates are conservative. They're conservative for several reasons. One, we assume no improper enrollment in states, in about 40% of states. That is because they don't meet our aggregate level for improper enrollment. We also include people that say they have employer-sponsored insurance as potential enrollees, even though those individuals aren't eligible for a Obamacare subsidy.
So it could be end up being much higher than 6.2 million if those employer people who technically are qualified to get employer plans maybe instead opting intentionally for these subsidies or are being improperly enrolled by these brokers. Is that what you're saying?
Yeah. So we don't exclude people that say they have employer coverage. It's difficult for us to do that based off of the way that the data works. So that's just another assumption that we made because we wanted to be conservative in the estimates that we put forward.
Okay. And so this is the third report you've pointed out. Um, and what's interesting is, well, one, the increase, right? And alongside the subsidies the that were enacted 2021. But it also seems that a lot of people were expecting the fraud problem and improper enrollment to go away once those subsidies lapsed this year. So maybe could you talk a little bit about how the problem has evolved over time and why haven't we seen a bigger change this year?
Sure. So the main reason we haven't seen a significant change, in my view, there's a couple of reasons. One, there's still a lot of fully subsidized plans. So in 2025, about 40% of enrollees had fully subsidized plans. And I should back up and say, in 2021, we've mentioned this, but President Biden signed legislation that expanded Obamacare subsidies and made the coverage in this group, 100 to 150 of the federal poverty line, fully subsidized. So they paid nothing for their premium. So in so massive incentives to enroll people and incentives not just for the enrollee, but for brokers and insurers. So to talk about this incentive for insurers, think about from the insurer perspective, they don't like having to bill customers for their share of the premium. So if the government is paying 100% of the cost, that's very easy for insurers. They don't even have to provide value from the plan for enrollees to enroll if they're paying none of the cost. And brokers, increasingly enrolling people in this market with the enhanced subsidies, they're getting a monthly commission for everyone who enrolls for as long as they remain enrolled. Okay, the enhanced subsidies went away after 2025. So, to your question, what explains the continued improper enrollment in 2026? Some of it is just inertia. It's that automatic re-enrollment from one year to the next. It's almost 40% of all enrollees this year were automatically re-enrolled from one year to the next. The second big reason is because the underlying subsidies remain very large. And even though one type of plan is no longer free, you can take that same subsidy and apply it to less expensive plans. And those less expensive plans, whether they are a bronze plan in every state or a gold plan in many states, are also free. So in the states where we've seen the highest amount of fraud, we've seen much more active broker re-enrollment of individuals. And what they have done is move people out of free silver plans, which were fully subsidized through 2025, into free bronze and gold plans.
So I do want to get to how the gold plans become free a little later. But when you talk about the problems in the states, where's the problem most severe? What do those states have in common? When I first started reading reading this study, I was a little surprised because usually I would think that the fraud problems would be worse in Democratic run states, but that was not the case here.
So let me start, and then I'm going to turn it to my colleague. So I was asked this question, and the reason that we started this work is I was testifying in the state of Texas, and a member of this Texas State Senate asked about what he was hearing from brokers about income manipulation to receive more subsidy than the individual's entitled to. And one of the big problems with that, I mean, you're getting improper enrollment, but the taxpayer is at the risk because if the insurer gets too much subsidy during the year for most enrollees, the government just takes the loss because there are limits on the amount that the enrollee has to pay back if the insurer that they chose got too much subsidy. Now, we expected the problem would be more severe in states that didn't adopt Obamacare's Medicaid expansion. As a result of Obamacare, so Obamacare had a very convoluted way of expanding health insurance coverage. The way that the authors thought it would work to try to fit their cost constraints was to expand Medicaid for people with income, for people with extremely low income. And then above that, to have these exchanges, what President Obama sort of advertised as these private marketplaces that were going to be full of competition and with this sliding scale of subsidies. But they didn't make any subsidies available in states that were below 100% of the poverty line if they didn't expand Medicaid. So in those states, there is an incentive to overestimate your income because then you qualify for advanced subsidy that you actually don't have to pay back. So what we've seen is in those states, a lot of overestimation to qualify for subsidies and being properly enrolled. And those states are primarily conservative states. The problem of underestimating income is universal. And if you control for Medicaid expansion status, I'd say one of the most surprising findings in our first paper is that the problem was much more severe in states that operated under healthcare.gov than operated their own state-based exchange. And there were policies put in place by both the Trump administration in the second term, as well as the Biden administration, that made healthcare.gov much more vulnerable to fraud and improper enrollment. And my colleague Elle I'm going to turn it over to her because she's an expert in what those reasons are.
Absolutely. So we do see a stark comparison between states that operate on the federal marketplace and states that operate in state-based exchanges. Healthcare.gov is what you should view as kind of the consumer portal to search, find, and apply for healthcare insurance. You kind of have two options. You can do this by yourself by logging on to healthcare.gov, or you can use the assistance of an agent or broker who will help do that process for you. And what we found is that in healthcare.gov states, states that use a federal exchange, they're permitted to use an enrollment intermediary called the Enhanced Direct Enrollment, or an EDE. So what that means is basically it is a third-party website that overlays onto healthcare.gov and is meant to make enrollment smoother and faster. But we have seen is that the influence of these enhanced enrollment entities led to a lot more fraud. Healthcare.gov, comparatively to the state-based exchange states, has less what I like to call front-end controls. So if you're a state-based exchange state, you are allowed to decide what special enrollment periods you have, how much paperwork or extra validation that you might have for someone that's applying. You also have access to state level data. So the state can look at state income tax data, they can look at the state Medicaid files, and they can also look at the state death file. So if someone were to pass away, if someone is also enrolled in the Medicaid program, or if they're misreporting their income, the state is able to use their own localized data sets to quickly compare and identify and raise those red flags. This is supposed to happen on the federal level through healthcare.gov, but what we've seen is it fundamentally does not operate nearly as well. So the state-based exchanges, who have a lot of different dials and controls that they can kind of move, are more easier able to have control on the front end intake, meaning they are able to see fraud before it comes into the system, versus the federal system where you get fraudulent applicants and then you're trying to find them on the back end. And overall, kind of with the authority of CMS and how the healthcare federal marketplace works, it's not nearly as effective as finding fraud after the fact. So the state-based exchanges are able to use all of these controls and all of this additional data to truly make sure that fraud is not entering the program, and so they don't have to find it as much retroactively. And that's because of a lot of things. We've also seen in the state-based exchanges that they aren't allowed to use enhanced direct enrollment, which we think is a major contributing factor to the larger levels of fraud in healthcare.gov states.
Is there any incentive for these states that operate their own exchanges to do this, to limit fraud? Because I'm just looking, the states that operate their own exchanges have also been kind of looked the other way when it comes to Medicaid fraud. And I'm just wondering if there are any particular financial or other kind of incentives for them to be tougher when it comes to the Obamacare enrollment.
Absolutely. So you kind of have to look at the ACA and Medicaid incentives here being a little bit different. In the Medicaid program, especially with the way that Medicaid is financed, there is a large incentive for states to maximize enrollment so that they can bill the federal government to receive that reimbursement from the matching rate. That's not how the ACA operates. The incentives here are much more between the insurance companies wanting more enrollees or brokers wanting more enrollees so that they can either maximize the cash transfers that they're getting from the federal government on a monthly basis, or on the broker end, maximize your total yearly and monthly income by having more people to get more commissions. There is not an incentive here. So if you have more Obamacare enrollees, the state is getting a larger paycheck, which is like you have in the Medicaid program. So when you look at states that have state-based exchanges, there's a little bit of a different incentive, and some of it has to come with reputation. If you're operating a state-based exchange where a lot of your state's citizens are being fraudulently enrolled in Obamacare plans, and as Brian mentioned, you have to reconcile the subsidies that you receive. And so oftentimes victims of enrollment fraud end up with large bills at the end of the year from the federal government because they were enrolled in a plan and received a subsidy that they were not eligible for. If you're in a state-based exchange and this was happening all of the time at a higher rate, you would get a lot more people calling into the state and saying, hey, what's going on here? So there's more of a reputation with the state to make sure that all of the enrollees in the state are properly enrolled so that they're not getting that kind of pushback. There's also an incentive with the state to make sure that there's no double dipping just inherently with the data that they're allowed to use. And the other thing here is there's a lot of reasons why you don't want fraud in your local ACA marketplace. It tends to distort premiums. When you look at premium increases after the expiration of the enhanced COVID credits, on average, premiums were 25% higher in healthcare.gov states comparatively to state-based exchanges. Now, this is because of a couple of other reasons. You have state-based subsidies or state reinsurance programs, but overall, this is also because there weren't any fraudulent enrollees that were distorting the risk pools or the kind of baseline that the insurance companies are operating in. And so it's a little bit different.
Let me jump in. I love the question, Alicia, because it was a natural question for us too, is why don't you have the same levels of fraud in the exchanges as you do in states where Medicaid fraud is so significant? Think about it in terms of the four biggest states. California has massive improper enrollment in their Medicaid expansion. And the group that would be enrolled in Medicaid expansion is pretty similar to this low-income group that would be enrolled in the exchanges. And while we think that duplicate enrollment in both the exchanges and Medicaid expansion is a problem, and we know that last year CMS identified there were 1.6 million enrollees, states where we see massive fraud in Medicaid expansion, we're not going to see as much improper enrollment, I should say. We're not going to see as much in the exchanges. New York is another case that's interesting. New York is excluded from our analysis. And one of the reasons why our estimates are conservative, a big reason, is because we excluded New York. New York operates what's called the Basic Health Program, which is a way the states can get federal money for this low-income population and have it in a state-based program. Bill Hammond at the Empire Center has done a similar analysis that we did on this and estimates far more enrollees than eligible in New York's basic health program. So New York has fraud both in Medicaid expansion to some degree, but they have an enormous problem in the basic health program. If you look at the two big red states, we see massive amounts of Obamacare improper enrollment in the exchanges. Florida is sort of on an island to themselves. I think that there is a culture of healthcare fraud in South Florida that has infected the exchanges even worse than in other states. If you look at the major Department of Justice criminal cases, all three major convictions, and we're talking here $100+ million in improper subsidy in each of these cases, they've all been focused in South Florida. We estimate that in Miami-Dade County, there are 7 to 8 times as many enrollees in this low-income category than are eligible. So Florida has a massive problem with the integrity of the exchanges. They actually had a problem that predates the COVID enhanced subsidies. We wrote about that in our first paper. Now the problem has escalated significantly because of the COVID subsidies. Texas is the final state, big state. And Texas, we're seeing an emerging problem in Texas, in large part because of their intensification of silver loading and the fact that the plans, both bronze and gold, are free for low-income enrollees.
Can we just, I'm going to pivot now to just ask about this. What is silver loading and how is it possible for these gold plans to be so much less expensive than, or in many cases, less expensive than the silver plans? To me, that's like paying less for first class than an economy seat.
Yeah, so when we have a great figure that illustrates the differences between bronze, silver, and gold. There were two original Obamacare subsidies. We've been talking about the premium subsidy. There was also a cost-sharing reduction program. The cost-sharing reduction program were payments from the Treasury to health insurers to reduce deductibles and out-of-pocket limits for enrollees that took that enrolled in silver plans. So for individuals in this income category, 100 to 150 of the federal poverty line, that meant plans that had very low deductibles and very low copayments. The COVID credits made these fully subsidized. So if you look at the situation in 2025, the typical enrollee would face an $87 a year annual deductible on a silver plan. In a gold plan, they would face a slightly higher premium. And you see the deductibles on there as well. And then you see the bronze plans, you see the deductibles on there. To come back to your silver plan, you can take that subsidy and apply it to any plan. So has I'm sorry. Let me finish the silver loading. The Obama administration was making unlawful payments to health insurance companies because the CSR program was not lacked a valid congressional appropriation. So members of Congress sued the Obama administration, and they won that lawsuit, and it went to an appeals court, and they won at the appeal level. The Trump administration decided to comply with the law and stop making those payments. Insurers still had the obligation to reduce deductibles and out-of-pocket limits. And what insurers did was significantly increase the price of a silver plan. Why? Because the premium subsidy is tied to the silver plan. So when the premiums went up, the subsidy went significantly up. So that's what we refer to as silver loading.
Okay. And how prevalent are these zero premium plans now? I mean, we keep on hearing in the press that people are paying, thousands of dollars a year, but I think you're for insurance, but there are many people who aren't paying anything. And do you guys have a good estimate of that?
Yes. So, and these are numbers that are reported by the Centers for Medicare and Medicaid Services every year. So last year, about 40% of all enrollees in healthcare.gov states, and about three-quarters of enrollees are in states that use healthcare.gov, had a zero premium plan. This year, because of the expiration of the COVID era subsidy boosts, it's about 30% of enrollees that are in fully subsidized plans. The median enrollee this year pays $42 a month for their premium. And it's a premium that overall costs about $740 a month. So the median enrollee is paying only 6% of the premium. 94% of it is subsidized. One of the things that got confused and intentionally, I think, misrepresented by a lot of ACA supporters that were trying to put pressure to increase these COVID era subsidies was the impression that all of the subsidies were going to go away. And the reality is the underlying Obamacare subsidies are very large, and they actually grow on autopilot because there is a cap on the amount that enrollees have to pay.
And why are these a particular concern from the standpoint of, program integrity and preventing fraud? I mean, how do these kind of supercharge those incentives for brokers to improperly enroll people and such?
Well, if the plan is $0 and a broker is receiving a commission payment that is anywhere from $30 to $70, depending on the state, it makes a clear incentive there to steward people towards the $0 plans or enroll them without their consent, which has been a clear kind of central theme of our research. And so in a lot of the policy recommendations that we have made, there needs to be some sort of skin in the game. And we would go as far to say as that monthly premium should be higher than the commission amount. And so it really tries to get at that incentive of as long as someone is making more money than what is being paid for by that plan, there's always going to be an incentive for more unauthorized or improper enrollment in that category.
And the incentives for the insurers, right? Insurers benefit from the zero premium plans as well. and the government fully subsidizing them. So you've got incentives for enrollees, brokers, and insurers. And if a lot of these enrollees, because we know from reporting, we know from the DOJ convictions, we know the Government Accountability Office showed they enrolled 23, so they created 24 fictitious applications and they successfully enrolled 23 people in coverage. If someone has been enrolled without their knowledge or consent, the way to keep them enrolled is for them not to have a premium payment. And that is how we think the fraud has persisted over time, is because you've had so many of these people in zero premium plans.
So what happens to those people who are improperly enrolled without their knowledge? If it's a zero premium plan, are there any downstream like implications or consequences for them?
Yeah, well, Alicia, the only person that faces a consequence in that scenario truly is the enrollee that was enrolled without their consent. The insurance company will continue to receive that cash transfer. They got it all year from the Treasury. The broker was paid a monthly commission for every month that that enrollee was enrolled. And then at the end of the year, come tax season, which, as you've explained, is in the spring of the following year, that enrollee or individual will go to file their taxes and they'll have their tax return actually denied. And when they look into why their tax return was denied, come to find out that they were enrolled in an Obamacare plan without their knowledge, and they face tax bills for that reconciled amount, which in some cases can be upwards of $7,000 to $10,000 for that enrollee to now have to pay back, even though they were the ones that were enrolled without their consent. In theory, CMS and some of the IRS are supposed to then claw that money back from insurers, but we know that that's a very difficult process that doesn't always happen. And then not only just the financial issue here of folks receiving tax penalties of thousands of dollars for plans that they never received and did not enroll themselves in, they also receive disruptions in their health insurance. We have a blog entitled The Victim of Enrollment at Any Cost Strategy. And that really details folks that were not able to get surgeries that they were waiting months for, folks that were turned away life-saving prescriptions that they needed to be on because it was no longer covered on their insurance, stories of babies in the NICU who are no longer covered and their parents had to pay for all of that cost out of pocket because that they were enrolled in these plans without their knowledge. And so the victims are truly the people that were enrolled without their knowledge and not actually any of these large profit entities.
Fascinating. You both did a report in, I guess it was last summer, about these phantom enrollees, which we wrote about on the editorial page, seems to be a related but separate issue to the improper enrollment. Can you just talk a little bit more about these phantom enrollees, how you define them, and why this distinction is important?
Yes. So last year when we did our improper enrollment paper, we were speculating that a lot of people were enrolled without their consent. This press stories were coming out. If you expect people to be enrolled without their consent, that they're unaware of their enrollment, what you would expect is that they don't use their health insurance plan. And unfortunately, the Biden administration did not put out any data on the extent that people were not using their health insurance plan and how that changed over time. In August last year, CMS finally put out that data. They put it out from 2019 to 2024 in the individual and the small group market. And what we did was look at the percentage of all enrollees that had no medical claims, and we just did a division and we plotted that over time. The figure that you see right here, the bottom figure, is in the small group market. So the small group market is an Obamacare regulated market, but the subsidy boosts did not affect that market. The top market is the individual market where the subsidy boost took effect. And after open enrollment, they were in effect from 2022 through 2025. A phantom enrollee is not a zero claim enrollee. A phantom enrollee is somebody who is enrolled, who is not aware that they're enrolled, who has other types of coverage, or is a fictional enrollee. We estimate phantom enrollees as being the number of zero claim enrollees in the individual market above what you would expect in a normal health insurance market, where the percentage of people with zero claims is about 15 to 20%. So if you look at this figure, the two lines are almost on top of each other from 2019 to 2021. That shows that zero claim enrollees in the individual and small group market were basically the same. Then what happened? Obamacare subsidies were expanded, and you have a huge increase in the number of enrollees that don't use their plan a single time. So basically, that difference between the blue line and orange line, that is our estimate of phantom enrollees. And there's more evidence to think that phantom enrollees became a bigger problem because the percentage of enrollees in fully subsidized plans, um, it was a higher percentage of those used no healthcare services during the year. So what's happening here? The person is enrolled by a broker. They don't know they're enrolled. The health insurance company is getting a check for every month they're enrolled. The broker is getting a commission for every month they're enrolled. The patient does not benefit from the program. They don't get any medical care. They don't know that they're enrolled.
Okay. Now, what has the administration done in order to counter these, both the phantom enrollee and the improper enrollment problem? And what do you think it still or could be done, whether by administrative action or Congress, to remove and eliminate these kinds of incentives?
So it did a really important administrative action first. So last year it did a program integrity rule, and the program integrity rule had several pieces. It required income verification prior to enrollment. Um, it provided for a $5 minimum premium payment for applicants that took no steps during the enrollment process. So you couldn't just be automatically enrolled into a zero premium plan. You would have to face a $5 minimum premium payment if you were automatically re-enrolled. It got rid of the Biden administration. Really, the Biden administration really focused on enrollment. We call it an enrollment at any cost strategy. They opened up a special enrollment period for anybody claiming income between 100 and 150% of the poverty line. What that means is that you just didn't have to wait for open enrollment to sign up. You could sign up at any point in time, so long as you claimed to have income in this category. And by the way, we're not going to verify whether you have income in that category or not. So it basically turned Obamacare into a continuous open enrollment process, which creates a really bad incentive for people to wait until they're sick to buy coverage and then misestimate income. Trump administration addressed that. They also did a failure to reconcile removal process. So the Biden administration allowed people to maintain coverage for longer if they failed to properly reconcile past years of advanced premium tax credit. The Trump administration addressed that. Unfortunately, this was a really important reg. There was a single judge who took action to strike it down. So most of those provisions did not go into effect. Now, the reconciliation bill, the one big beautiful bill last year, contained many of these provisions. It did not include the $5 minimum premium payment, unfortunately, but it included many of these provisions. But for the most part, they haven't taken effect yet. So while the Trump administration has done some actions, the special enrollment period that is over, there's still a lot out there that they can do. One of the things that we think they should do is suspend brokers and agents who have clearly been involved with fraudulent enrollment schemes. The Biden administration took steps to suspend 850 brokers in the summer of 2024. Now, they did that sort of they didn't go through the proper processes, and the Trump administration reinstated those brokers because the Biden administration didn't go through the proper processes. I think they need to address these, because the vast majority of brokers we think are good and upstanding, but there are a handful, and in these like enrollment brokerage factories that they need to suspend and not permit to enroll people in the program.
And Alicia, to build on that just very quickly, I think, as Brian said, there is a need for CMS and the federal government at large to kind of update the way that they go after these actors and understand where their authority is. This is not a conversation when we talk about broker fraud. We're talking about individual people that are trying to help enroll people in health insurance. We're talking about the now large enrollment conglomerates that have sprouted up as a result of the Affordable Care Act. So the marketing companies that go on Facebook and advertise the subsidy as a cash gift card, the lead generation companies that take people's personal information, whether that be your name, birthday, address, phone number, and sell that to folks to then try and target you for health insurance, enhanced direct enrollment, all of these enrollment intermediaries that did not exist when CMS started healthcare.gov, really making sure that we have the authority and the oversight across the spectrum to be able to go after this. And then on a more common sense level, which is something that the state-based exchanges do, multi-factor authentication. So when I order Taco Bell or Uber Eats, I have to type in that code from my phone before that order will go through. If I'm making, as a broker, if I'm making changes to your health insurance, I don't have to get your approval first. There's no code that's sent to your phone. There's no email that you're clicking on to make sure that you're approving that. And so things like that, really making sure that the enrollee is active in their health insurance, making sure they're the ones that are in the driver's seat when it comes to making changes, will really help with the technical levels of getting at all of this fraud.
Okay. All right. I want to ask one more question before going to the audience. The insurers would argue that the medical loss ratio requirement in Obamacare, which would basically requires them to spend at least 80% of the premium dollars on medical care, really means that these, or 85%, okay, these phantom enrollees with no medical claims, would be holding down premiums for everyone else, and they can't just, they're not effectively benefiting from the enhanced subsidies or any of the fraud. Can you address those criticisms?
Yes. So Obamacare, it's a great question. And I think at a first approximation, that's probably how a lot of people think about it. They think, okay, these individuals are coming in improperly enrolled, maybe they're phantoms, they don't have any medical claims. So that's going to reduce average premiums in the market because we're going to spread that no medical claim over larger number of people. The medical loss ratio is one, I think it's increasingly something that I'm thinking is one of the most important parts of Obamacare and is affecting much more than just the way that the individual market works. It basically says to insurers, you need to spend a certain percentage of premiums on claims. If you do not spend that percentage on claims, you have to rebate the money back to the policyholder. Insurers don't want to engage in this rebate process. Looks bad for them. Looks like they set initial premiums too high. So they have incentives to make sure they hit their MLR. Now, they don't want to go much over their MLR, but they definitely want to hit their MLR. And the MLR is the way that it's calculated is based off of a 3-year average of the past 3 years of experience. So what I think has happened is you have insurers that have received a bunch of revenue on behalf of individuals that aren't using any medical care, but they have an incentive to make sure that they spend a certain percentage of all the premium revenue that they get. So they are weakening utilization management and controls on the high end of the market. And so we're going to look at this at Paragon because I think this is, we sort of study the incentives that government programs create, and we love to talk about the perverse outcomes. But I think perversely what we're seeing, and we see some initial support for this in the data, is a huge growth in high cost expensive medical claims, where insurers have this incentive to not have proper utilization management on that side, because if they did, then they would go underneath their MLR and they'd have to make rebates.
All right. So questions from the audience. I'm going to combine a couple. Someone asked about the most recent ACA enrollment numbers, which may not be reflective of the enrollment numbers of January, and how would you expect those to be different, and how could CMS provide more visibility into the data, rather these periodic releases that we get?
Yeah, so it was good that the Trump administration released the data on zero claim enrollees. That is something the Biden administration didn't do. What we're going to see next is effectuated enrollment. And it's going to be effectuated enrollment means the individual paid their premium. Our analyses across our report this year and the reports the last couple years have been after open enrollment, because after open enrollment, they report the data by income category. We haven't seen much enrollment attrition over the last few years. Now, partly that's because so many more people are enrolled in fully subsidized plans, and if you don't pay a premium, it's harder to get off the program. And also because of the special enrollment period, you're adding people during the course of the year who are coming on to the program. This year, they got rid of that special enrollment period that was subject to widespread abuse. And there are fewer enrollees that have zero premium plans. And the Trump administration has taken these steps to remove individuals that have both exchange coverage and Medicaid, and people that haven't properly reconciled their tax returns. So I think you're going to see a decline that is larger than the past several years. If you go back to pre-COVID Obamacare, average attrition, meaning if you look at average enrollment during the year and compare it to open enrollment, it's been about a 20% decline. If you have a 20% decline after this open enrollment period, you're probably looking at the market coming into between 18 and 19 million enrollees by the end of the year. Now, importantly, that is still a much bigger market than pre-COVID. I mean, we're talking about a market that is almost double what it was pre-COVID.
And how would you expect? So someone asked, wouldn't you expect the requirement to reconcile income and pay back the excess subsidies to wring out the improper enrollment? So come next year, maybe would you expect that to contribute to reduce enrollment when people have to pay? Okay.
Yes. So that, and it is important. People below 100% of the poverty line that overestimate income, and a lot of this, they could, I mean, a lot of people below 100% of the poverty line are working off the books too, but officially on the books, they're below 100% of the poverty line. There's no subsidy recapture amounts for them. So if they get too much subsidy, they don't have to pay any of it back. But for people who underestimate their income, a provision of the reconciliation bill requires those amounts to be fully reconciled. And that's the first time in the program history that's going to be in place. And I think those are important, and that will eventually reduce enrollment in the exchanges. A lot of it too, Alicia, honestly, people don't value the Obamacare coverage that much. I mean, one of the main things that we've seen is that in order to get enrollment, you need to have people that the government, somebody else, taxpayer, needs to cover the vast majority of the premium. So it is a question, I think a legitimate policy question, if an individual is going to go from like a $10 premium to a $30 premium for a plan that costs $800 a year, and they don't value it at $30, like, is that, like, how should we think about the overall social good of somebody that will only enroll in a plan if the government is subsidizing more than 95% of the cost? And some disenrollment is going to happen just because Obamacare plans are unpopular and people don't even want to pay a small fraction of the cost.
Right. So do you guys have any estimates about how many per share of improper enrollees are below 100% of the poverty line and above 100 versus, those who are above and just understating their income?
We do estimate that in the paper, and so the precise estimate is in the paper. Off the top of my head, I think it's probably about 50-50, and then we think it's people below 100, and then people who overestimate, and then people who underestimate, who are above 150.
Uh, Another audience member will ask, how are brokers quote unquote regulated, or are they regulated?
Ellie, you're on mute.
It's a bit of a difficult process. They're regulated through a series of different bodies. In order to sell health insurance, you have to have a health insurance license, which is given out by the State Department of Insurance. They are also regulated through CMS. So in order to sell health insurance on the individual marketplace within the ACA, you have to go through annual training and or registration with CMS. But the process truly gets to be a little bit precarious when you understand that each insurance company has different contracts. So if I want to sell United or if I'm going to sell Oscar, I have to have a contract as a broker with each of these different insurance companies, which kind of gets at the incentives that we were talking here about earlier. These insurance companies are essentially employing these intermediaries, agents, and brokers to go out there and sell their insurance. Well, insurance companies only give out a certain amount of contracts every year, meaning not every broker is going to get a contract. And so there is an incentive here for the insurance companies to give out limited contracts and to give out contracts to more precarious or unscrupulous brokers because they will maximize enrollment compared to a traditional independent broker that is really trying to do well by the business.
And then someone asked about what action should the government take to address the silver loading problem?
Hey, could you bring up that figure again that shows the enrollment by or the premiums by metal tier? The silver loading, the best action to address silver loading is to prohibit silver loading and appropriate the original cost sharing reduction program. So Obamacare, according to the original design, it works better if you have the cost sharing reduction program as a separate subsidy program. We actually have a proposal at Paragon called the HSA option, where we think CSR should be appropriated. That would lower and ban silver loading, that would lower the silver plan premium, that would lower the subsidies, and give people the CSR subsidy has an option to take into their HSA. We want government subsidies to go more directly to individuals rather than flowing directly to health insurance companies. And we think people with low income enrollees should have an option to take that contribution as an HSA. The figure that I brought back up, I just want to illustrate because I think this is one of the most important findings in the paper is the shift that we've had from silver plans to non-silver plans. In 2026, the COVID credit went away. There is now a premium for the silver plan, but the premium for the silver plan is pretty low. It's $335 a month for a plan that has an $80 deductible. So the total out-of-pocket limit for that enrollee is $415. That's basically their maximum financial exposure. They could choose a bronze plan that has no premium because of silver loading, because they can apply the subsidy to the bronze plan, or a gold plan that has a small premium, but the deductibles are much higher. What we have seen in 2026, so I think the point of this is it's in the financial interest for the vast majority of low-income enrollees to be enrolled in a silver plan. If you go to the next slide, it shows a huge enrollment drop in healthcare.gov states in silver plans. So the percentage of enrollees choosing silver plans went from over 75% down to almost 50% in healthcare.gov states, while it remained basically the same in the orange line, which is state-based exchange states. Why is this important? This is important because there is much more enrollment um, of brokers in healthcare.gov states. And it goes to the point where we think a lot of these unscrupulous brokers have taken people out of the silver plans into the bronze plans, even though it's against the best financial interests of silver plan enrollees, because that is a way to preserve their commissions, because the commission is preserved only if they maintain them in a zero premium plan.
Okay. I think we probably have time for one or two more questions. So someone asked, did the program integrity efforts that were not stayed by the courts that the administration implemented, like three-way calls, have any impact on the improper enrollment?
That's hard for us to know. Elle, I don't know if we could speculate on that.
Okay. Here's another. Is there for opportunities for people, to file kind of whistleblower actions against the brokers or such who are improperly enrolling people?
Yes, absolutely. Not only can you report them on the federal marketplace, but it's also really important that anyone contacts the State Department of Insurance, because that is where they are most likely to kind of get control of it quickly. Then they'll be able to flag that to CMS.
I mean, this is probably the last one, but again, why haven't the improper enrollments, sorry, my lighting in it's the 2005 energy bill, to blame. Why haven't improper enrollments fallen more since with the expiration of the subsidies? Are we going to see that now? I mean, you went from 40% to 30% free people in free plans, but is that the reason, or are there any other reasons why the improper enrollments haven't declined more?
Well,
I'm sure
the first iteration of our paper, we named the Great Obamacare Enrollment Fraud, and then the problem got worse in 2025, so we named it the Greater Obamacare Enrollment Fraud. This year, it persisted, right, at 27% of all enrollees, so it's the persistent Obamacare enrollment fraud. And I think the main reason, so silver loading and people having access to free bronze and gold plans, and the incentive, and we know where brokers are more heavily involved in the applications, there's more improper enrollment, moving enrollees into free bronze and gold plans. So still the availability of fully subsidized plans, as well as automatic re-enrollment, was a big factor in 2026 as well. And the Trump administration program integrity efforts, and even those in the One Big Beautiful Bill, they just for the most part haven't taken effect yet. I do expect when we write this paper next year, we're going to be able to say something about like the declining Obamacare enrollment fraud. I expect there to be, I expect and I hope that we have much less improper and phantom enrollment in the exchanges. It's clearly not fair to taxpayers. It's not fair to legitimate enrollees. And I think it's going to be a measure of whether the actions of the Trump administration have been effective or not.
Well, I think like when you look at this on a technical front, for in terms of what are we looking at the fraud and how it exists with brokers, etc. As Brian said, this is the most that we know about this fraud in any paper that we've done, and so I think as we start to further learn, and as the Trump administration and CMS gets a further grasp on what they can do to promote program integrity, you're going to see that go down. But as we said before, there is more tech and confusion in terms of ACA enrollment than ever, with all of these different intermediaries and enhanced direct enrollment entities, etc. And so we kind of can compare it to where you are with the start of digital banking. And so I think, as Brian said, I hope that the fraud will continue to go down in the next years as we get a better handle on how the entire program works.
Okay. Well, great. Thank you so much. I think that this was very informative for me and the audience.
Well, Alicia, thank you for moderating the discussion, for the attention that you and the Wall Street Journal editorial page have paid to this important issue. Thank you, everybody, for participating. We got lots of great questions and audience engagement. If you want to learn more about this work and any other area of research that Paragon has done, go to our website, paragoninstitute.org. We're going to have our next virtual event in 3 weeks, which is going to be a conversation between our Medicare reform director, Demetrius Kouzoukas, and the outgoing chair of MedPAC, Michael Chernow. Thank you, and have a great rest of your day.